everyone. My name is Ronald Blanton. I am the Henderson Chair in Prevention of Tropical Diseases here at the Tulane University School of Public Health and Tropical Medicine. And one thing that we have tonight is that throughout this dark night of the pandemic, we have reached periods of that have been terrifying heights, as well as periods of relative calm in which we have been able to look back at just what happened and reflect on them naively, thinking maybe we were looking for brighter days. But each time that we have had these periods, we have learned a little bit more about our view of the pandemic, and the view of the pandemic has been a little bit different. This is one of those periods, although at this point we have no idea of what the future really holds. But it is a time that we can begin to think about where we've been and perhaps look forward to where we're going. We are in the midst of an ongoing COVID-19 pandemic, and tonight we will highlight the stellar work of our faculty as we discuss the Delta variant, the COVID-19 vaccines, vaccination rates, booster shots, and other topics. Tonight you will hear from two of our most knowledgeable faculty experts, namely Dr. Susan HASSIG and Dr. David MUSHATT. With us tonight, they will share their experiences. Dr. HASSIG received both her MPH and her DrPH from the Tulane University School of Public Health and Tropical Medicine. She has been a faculty member of the Epidemiology department since 1996. And after more than a decade of working in HIV research, surveillance, and intervention programs in the US and around the globe, she has also served in the Peace Corps, where she worked to improve diseases, diagnosis, and blood transfusion safety in Thailand. Our other discussant is Dr. David MUSHATT. He is a professor of medicine and section chief for the adult infectious diseases. He received his MD from Harvard Medical School and completed his internal medicine residency training at the Brigham and Women's Hospital in Boston, and then did an infectious disease fellowship here at Tulane University School of Medicine from 1989 to 1991. During the second year of his ID fellowship, he also earned an MPH in tropical medicine at the Tulane School of Public Health and Tropical Medicine. Dr. MUSHATT is the principal investigator of the Louisiana Community AIDS Research Program and the Tulane Clinical Trial Site that was formerly part of the CPCRA and now part of INSIGHT, an NIH-funded international HIV research group that focuses on strategies in HIV treatment at the community level. At this time, it is my pleasure to turn the program over to Dr. HASSIG and Dr. MUSHATT. Once they are done, questions will begin. We have had numerous questions posed with individual registrants before the webinar, and we thank you for that. And in addition, we will answer as many questions as we can from tonight's chat. And in questions that can't be answered during the webinar, we will still try to answer afterwards by email. Dr. HASSIG.
We have the next slide, please. I want to start out with a global view, since this is a global pandemic and it won't be over for any of us until it's over for all of us. The red graphic up in the upper corner gives you a sense of the global occurrence of cases, and the different peaks represent different times. The first big peak is our winter surge here in the United States, followed by the surge in India with the first experience with Delta, and then our own and others' global experience with Delta in that final surge. The white bars below it are the mortality data, the people that have died to date on a global scale, probably underreported, as are the cases above. And then the final and the geographic map distribution that's reflected here is the real true hope for us in getting out of this pandemic, which is vaccination. As you can see from the global numbers, we have distributed billions of doses of vaccine to date, but our global population is over 7 billion now. So we still have a long way to go. And the distribution has not been equal around the globe in the different regions and countries that are in need of this product. So that is something we will be discussing as we move forward. Next slide, please. To bring things in a little bit closer, this is the experience that we've had collectively within the United States in terms of infection. I would remind everyone that this is in fact an underestimate of the actual infections that likely occurred at any given point in time, certainly at the very first stages of the pandemic, when, if you recall, we had very little testing available. The most striking feature of this is that, again, that winter surge that we experienced in December and January, when we had very high case burden and very high hospitalization and mortality experience. The final peak that is represented on this graphic is the Delta experience in the US. And you'll note that it's not as high as the midwinter peak of just 11 or so months ago. And this is very likely due to the fact that we have been able to vaccinate such a large proportion of our population. Although, as with this pandemic on a global scale, it has not been equally experienced within the United States. Next slide. I've included on this slide 3 different pieces of information. The upper left-hand figure is the mortality information, the daily mortality. You can see again, we had our greatest mortality experience in December, January 2021, and a much lower mortality impact, although still high in our more current Delta peak. The graphic below that upper panel is the vaccination rates at which we moved vaccine doses into the US population. And there was a lot of interest and uptake in the early days of the vaccination process. And you can see that we are not doing as well now as we did initially. I've positioned them so that they're roughly temporally aligned. And so you can see that the vaccinations we experienced in January and February are probably what is helping us now with the Delta mortality experience in July, August, and September. The map of the United States gives you a sense of the relative success in getting a proportion of the population vaccinated. And again, this is one of the challenges we will face as we move forward through this pandemic and hopefully to its conclusion, is that we do not have equivalent levels of vaccination geographically distributed by state and even by county within states. And so this is going to continue to be a challenge for us, encouraging and facilitating the uptake of a very safe and effective product to help us bring this pandemic to a place of containment and closure. Next slide, please. I'm going to close with a couple of slides looking at the data that I know best, which is the Louisiana data. And for those of you that have not been here with us in Louisiana, we have had a rough ride. And there are some distinct differences in our experience than the US national experience. And mostly I would point to that 4th peak that you see on the left-hand graphic, which is cases of SARS-CoV-2 being found and reported in the state of Louisiana. We had a very, very harsh July and August with Delta here. Cases rose incredibly fast. Hospitalizations followed, as you will see shortly. And you can see we've had more cases being diagnosed in July and August than we did in December and January by almost a factor of 2. This was also in the right-hand graphic, not something that was experienced equally within our population when we look at it by age. And if you have time to take a look at the slides at some later point, perhaps you'll see that the lines that reflect the older individuals within the Louisiana population, who are by far the highest vaccinated groups within Louisiana's population, they had the fewer number of cases in this Delta surge, which has worked substantially to mitigate the impacts that coronavirus has had upon us. Although, given our level of unvaccinated population, we still had an incredible burden here in the state. Next slide, please. I've got a lot of 3 panels again on here just to kind of wrap this up. The first panel, the upper left-hand panel, is hospitalizations here. And you can see that we went straight up in hospitalizations in July in Louisiana to the highest level we have ever been at, over 3,000 people hospitalized in Louisiana. It was a terrifying time. And it has dropped quite precipitously since that time, which is a tremendous relief to all of our hardworking healthcare providers. But we also experienced a lot of mortality in that time frame. Mortality was equivalent, if not higher, to all of the peaks that we experienced, including the very first one, when we knew nothing about the pandemic. And so this is, I think, an ecologic reflection of the fact that we had so many people who were unvaccinated and thus fully open and susceptible to the worst that COVID could do to them. The last and bottom graphic is showing you how Louisiana has done with vaccine uptake. And the gray line that is above most of the bars in Louisiana is the US average vaccination levels as a country. The red line is the Louisiana average vaccination, and the blue bars are the actual doses that were administered, or the people that were fully vaccinated in this graphic. You can see that we did great until maybe January. And then all of a sudden, even though eligibility expanded, our uptake dropped quite dramatically. We saw a bit of an upsurge as Delta began to hit us. People got concerned, got scared, and uptake was improved, but it did not last. And we are now back down to, unfortunately, very low levels to try and work our way out of our relatively unvaccinated state. That's the last of my slides, so I'm going to hand it over to Dr. MUSHATT.
HASSIG. Thank you, Dr. HASSIG. I see I'm unmuted now. If I can have the next slide, please. Welcome Tulane alumni, friends of Tulane, and community members. It's great to be here. Thank you for turning out for this. So this is the New York Times tally of vaccines. Actually, some of these are not in the US. These are the 12 leading vaccines throughout the world. And you can see the 3 vaccines that are currently available in the US are denoted by the red arrows to the left. So we have the Pfizer and the Moderna, the mRNAs, and the Johnson & Johnson, or J&J, which is the adenoviral vector. In addition, there is a 4th vaccine made by Novavax, which actually looks quite promising. The data looks pretty good. The reason it's not yet out there is that they are experiencing some production problems. The FDA has some concerns about quality at some of the facilities. Novavax is actually utilizing some other companies' manufacturing facilities, and they're having some challenges with quality, and so that's being worked on. I believe Novavax has promised billions of doses in the new year, so hopefully we'll see that in the near future. So next slide, please. So on the left are the COVID vaccination rates in the US. So the good news is that overall, 57% of Americans are fully vaccinated. 2/3 of Americans 12 and up are vaccinated, and almost 70% of those 18 and up are vaccinated. And the really good news is that for those who are 65 and older, 96% have received at least a single dose, and almost 85% are fully vaccinated. So this is certainly promising news. If you look at the graph on the right, though, you see that the number of daily doses of these vaccines is at about 850,000 doses per day. It's certainly far below the peak that was over 3 million daily doses back in April. Those are the heydays when there was a lot of vaccine excitement. But of course, we're down to the smaller numbers of people that are vaccine hesitant and skeptical, and therefore it's been harder to get these numbers up. But it is continuing, and now we're starting to see increases in the number of boosters that are being deployed. Next slide, please. So this is something you can go to. It's actually free. It's put up every few weeks and updated by the medical letter. I've actually taken out a lot of it because it's a very busy slide, but I just want to highlight the vaccine efficacy for the 3 current vaccines in the US, and this is pre-Delta. So I think we all know that Pfizer and Moderna were about 94 to 95% effective against symptomatic infection, and Janssen was a bit lower at about 72%, at least in the US data. Next slide. Unfortunately, we now live in the era of the Delta variant. This Delta variant is the dominant variant. If you look here, this is the CDC's tracking through sequencing of isolates around the country. And you can see that, and this is actually somewhat of a projection here. They're usually 2 or 3 weeks behind, but the projection is that at least through October the 9th, the vast majority of isolates in the US were and are the Delta variant at about 99.9%. So there are very few other variants circulating. I will say, if you look at the global map, there are some other variants in other parts of the world, in South America and elsewhere. In some countries, some of the variants are dominant, but overall, the global pandemic is very much exemplified by the takeover of Delta due to its superior transmissibility. Next slide, please. So this is a busy slide, and I'm not going to make it easy. I'm going to make it easier for you by highlighting some things. This is a slide of data that was presented to the ACIP group, the CDC's Advisory Council on Immunization Practices, back in August, which compares the Pfizer Moderna effectiveness versus both the previous Alpha and the more recent Delta strains. Alyssa, if you could right arrow for me, please. So what I'm highlighting here is the impressive efficacy of both vaccines in all countries where they were studied against hospitalization, severe illness, or hospitalization and death. So upwards of 90 to 100%. And I think we've all been reading that and hearing that. And I think that's clearly shown by this data. Next, right arrow, please. Now, however, the numbers, the efficacy does drop when you look at simply infection. Either infection asymptomatic or symptomatic. The numbers are particularly in the Israeli data, a little bit higher in some other area data. So I think what we've learned is that these vaccines do an excellent job of preventing progression from symptomatic infection to severe disease, hospitalization, mechanical ventilation, and death, but they're not quite as good at preventing initial infection. And if you ask somebody like Jay Coles, an eminent immunologist at Tulane, why this might be, he says it makes perfectly good sense. We can't expect the vaccine to prevent binding of the virus to the ACE2 inhibitors in the nose, as well as they can prevent spread from the nose, from those receptors and cells to the lungs and other organs. So this is not a big surprise. Interestingly, up here on the left, in the UK and Canada, they actually spaced the second dose by a much greater interval than what we're used to. We're used to 3 to 4 weeks. They spaced it by 12 weeks. And what you see is that they actually got better results. So that's an unanswered question, but it does raise the possibility that if one delays subsequent doses, one might get greater efficacy. Next slide. So this is an interesting study that was published about 2 weeks ago in Lancet on October 4th, looking at the waning of the Pfizer vaccine immunity over time. On the left, we have vaccine efficacy in terms of prevention of infection, and below is vaccine efficacy in preventing hospitalization. And on the right, they break down the efficacy in preventing infection by variant. And what you see is that, as we've read and heard, there is a secular decline in immunity over 4 to 5 months. And this is not terribly surprising. However, the ability of the vaccine to protect against hospitalization appears to be well preserved through at least 5 months. And if you break it down by variants, with the Delta being this purple line and others being the red up here, what you see is there's a decline in immunity for all the variants. So what that would tend to suggest is that this decline in immunity over time is probably more due to time after vaccination, to an actual waning of immune response, than it is due to the emergence of the Delta variant, although we certainly cannot exclude some component of the Delta variant playing a role. Next slide, please. So as of last week, we can ask who's eligible for a COVID vaccine booster shot. So for anybody who's at least 6 months out after their last dose, certainly for Pfizer, it's been approved, and for Moderna, that should be approved by the ACIP group and CDC later this week. And for the J&J, the FDA last week recommended that that be given as a second dose booster at least 2 months after the previous dose. And again, that will be taken up this Thursday by the Advisory Council on Immunization Practices, which should then be approved by the CDC. In addition, the boosters are being recommended for anybody who's 65 years and older, and anybody who's at least 18 years of age who either lives in a long-term care setting, has an underlying medical condition, or who works in a high-risk setting. And so the next slide will show you just examples of what are the underlying medical conditions. They include cancer, cerebrovascular disease, chronic kidney disease, COPD, diabetes, obesity, pregnancy, sickle cell disease, and other chronic conditions. And then the next slide, please. These are the high-risk settings. So of course, our first responders, such as healthcare workers, firefighters, police, teachers, people working in food and manufacturing, corrections workers, postal workers, et cetera. These are all people that are on the front lines who are particularly high risk of getting infected and getting a heavy exposure. Next slide, please. And who is eligible for a third dose? This is not quite the same as a booster. The third dose is the term that's used for those who received either the Pfizer or Moderna vaccines who were not likely to have a good response to the vaccine in the first place. And that's because they're moderately or severely immunocompromised. If you have a solid tumor or leukemia, or you're a solid organ transplant patient, or you have advanced HIV/AIDS and are not on treatment, you probably will not respond as well. Your take of the vaccine won't be as good. And so the CDC now is recommending that those individuals receive a booster or a third dose, at least 28 days after the second dose. We don't have a lot of data as to how well this approach works, but certainly in the transplant literature, there is evidence that solid organ transplant patients have an appreciable increase in antibodies and therefore presumably protection. Next slide, please. And finally, a lecture wouldn't be complete without some mention of vaccine efficacy, or safety rather. This is my favorite page on the CDC website. It's the selected adverse events reported after COVID vaccination. And on one page, they do a beautiful job of summarizing it. I'm not going to go into details. You can look this up yourself. But here's the good news. Over 400 million doses of these vaccines have been administered in the US between December and early October. Boy, that's a lot of vaccines. And if there were some bizarre, sneaky side effects, I think we'd probably know by now. And if you look at the number of people who have been reported to have died in relation to the vaccine, yes, there's almost 9,000 people that have been reported to have died. But in fact, when you drill down and look at those, the vast majority probably died for some reason totally unrelated to the vaccine. They may have already had COVID and got the vaccine too late. Some were frail in nursing homes and probably were at risk of dying anyways. And so the number of true deaths from this vaccine appears to be extremely small. But here are some of the breakdowns. So there are people that have a small number that can have anaphylaxis. But I like to tell people I would rather have anaphylaxis and get my EpiPen than end up in the hospital on oxygen and get intubated and know that I may not make it out of there. There are some people who get the thrombosis syndrome, but again, it's rare. And particularly if you're younger, if for a female less than 50, you may want to think about getting one of the mRNA vaccines. Myocarditis and pericarditis are largely young men, and they almost all have fully recovered. Okay, so this is something you can use, I think, to when you counsel your patients and your colleagues. And with that, I think that may be my last formal slide. Thank you. So I believe we can move on to the Q&A session now.
You both, that was very informative. And I think it obviously has stimulated questions before the webinar and here. Because David just recently presented a lot about vaccination, there was a question that came in. I wanted to see, and it's very topical, if he could comment on. And the question is about Colin Powell, that what is the efficacy of vaccine in people that have cancer and cancer similar to his? I think it's a question that will come up.
Yeah, so obviously that was a very sad, event yesterday to hear about that. And at first I was a bit stunned because my image of him is as being this strapping, healthy, vigorous man. But he died at at the age of 84. He had multiple myeloma. He was going in for treatments. And so when you look at his age and you look at his underlying malignancy and the fact that he was probably getting chemotherapy, unfortunately, he's in a very high risk for progression once infected and for intubation and or death. So I hate to say it, but it's not that surprising. Yes, he was vaccinated, but the vaccine may not have, he may not have responded as well to the vaccine, or even if he responded, he may have had some decrease in antibodies. We don't know exactly why he died. We don't know if he got the monoclonal antibodies, but we just have to remember that the vaccines are not perfect. They're really good. They're extremely good, but they're not perfect. And these kind of exceptions are going to be out there.
I think 2 points. One, this is not all cancers are the same. And this is a condition that's notorious for people being immunocompromised. It affects the ability to make antibodies to begin with.
Exactly.
And the point was made that this emphasizes the importance of everybody being vaccinated, because there are people out there that are going to be susceptible, even though they're trying as hard as they can to get around it. Susan, the question came in is, if I am fully vaccinated, should I continue to get tested? How often and why?
That's a good question. And I think it plays off of David's response from the question about Colin Powell, is that the vaccines are really good, but they were not assessed in terms of their ability to prevent infection. And so we don't know exactly how good they are in controlled settings. And with especially Delta and any future variants, which are likely to be very transmissible, we do know that vaccinated individuals can become infected and can, for a short period of time, potentially transmit it to others. And so I think particularly now with the holidays coming up, even if you're vaccinated, it might not be a bad idea to consider a pre-gathering testing round for everyone that's going to attend, to make sure that no one is inadvertently bringing in, even into a fully vaccinated group, infection that could pose some serious problems for people that are particularly susceptible to serious outcomes. The frequency of testing, I think, depends on your own situation. If you are interacting with people who are unvaccinated potentially, or otherwise engaged in high exposure kinds of environments, you might, and you interact perhaps with susceptible individuals, elderly grandparents or whatever, you may want to test before visiting those individuals, for example. Testing is widely available now. There are commercial test at home options as well.
I was just going to ask you, how did you know that was the next question?
I'm psychic.
How critical, David, is the booster? What factors would play into a decision to get a booster? And that is being congregate setting, flight plans. Are there new variants that will potentially disrupt the progress we are making? Any ideas?
Yeah, well, we don't truly know how critical the booster is until it's been out there for a while, right? So a lot of this is theoretical and speculation, but I think it is important. How important it will be, we really will know, probably next year. But I think that the data suggests that when you give boosters, you get better antibody responses. Certainly the Israeli data shows as much as a 20-fold decrease in severe illness in those who have received the booster versus those who do not receive the booster. So that's pretty impressive. And, yes, there will be new variants. We've all heard about the Mu and Lambda variants that we were starting to see, but then Delta took it over. I'm kind of glad in a way that Delta is squeezing out the other variants, as bad as it is. It's a known entity. And we know that our vaccines and our monoclonals work reasonably well. But I'm sure at some point, as the famous Bob Gary, the world famous virologist at Tulane, is want to say, this virus still has a few more tricks up its sleeves. It mutates about every 10 to 15 days. And there's a recent study just came out a day or two ago that shows that children probably can and will serve as a reservoir, even that they do have high viral loads. And even though they don't get terribly sick, there will be mutational evolution. And I'm sure we'll see variants. We just don't know how long the Delta will last and how long it'll squeeze out the variants. But as more people become immune to the Delta, we may start to see some of the others. I think that, you know, the good news, and this is leads to the next question, is are there any vaccines that could be improved that will such that we'll see fewer vaccinated individuals getting COVID? And so the good news is that the NIH has put out about a couple of weeks ago, put out a request and actually has awarded funding to Duke, the Brigham, and I think the University of Wisconsin to develop pan-coronavirus vaccines. These groups already have some ideas. And this is very exciting because the idea here would be that these vaccines may be able to anticipate changes in the virus, in the coronavirus, and in the variants, as well as other coronaviruses. And so this would be the holy grail. But there's also, you know, some thought that if we simply get really good boosting responses with the current vaccine, we may still be able to achieve very good protection against upcoming variants.
It seems that all our discussants are psychic. That's question number 3. David, this is, of course, the question that is on everyone's mind is, how long is this going to last?
Well, I mean, I truly don't know, and I'm not sure anybody knows. But I think it's going to be around for quite a while. You know, a year and a half ago, I just sort of assumed it would be gone in 6 to 12 months. That was we were engaging a lot of wishful thinking. But, you know, this is a cold virus, so it's very likely that it will become endemic, and that it will, you know, hopefully after the surge, get into a pattern where we have maybe smaller local outbreaks if we can get enough people vaccinated. And enough people achieve some degree of immunity. But the problem is that those who became immune a year and a half ago from infection will lose some of their immunity. And so we probably will see an ongoing transmission pattern here. I think, you know, some of the things to think about that could make this more manageable are the what are imminent oral agents, antiviral agents. The Merck has a very promising oral agent that may be approved by the end of the year, and there's Pfizer and a few other companies have some antivirals. That the Merck product seems to be able to reduce hospitalization by 50%. So the way I look at it is we can get something like Tamiflu, which we use for influenza, where people can call you and you can prescribe it. You don't even have to bring them in. You just say, look, it's been 2 days since you had onset of symptoms. Go to the pharmacy immediately, take this, and it will make you feel better quickly and keep you out of the hospital. If we can achieve that with these new oral agents, I think we will see a paradigm shift in how this is managed. It will be both reassuring and also give people something they can fall back on so that they don't end up in the hospital. So that hopefully will become a more manageable disease.
Susan, how long is this going to last?
I think we've still probably got a while yet, because we are really challenged in getting vaccine and the protection that it provides to a very large swath of the global population. And in those populations, they are ripe for variant production and mutation and later expansion. So I think we need to remain attentive and aware and recognize that our vaccine products are doing a fantastic job, and we can augment them through some, you know, selective behavioral choices that we each make as we move through our daily lives and make those decisions. So I think it's going to become I don't want to compare it to flu, but I think it's probably going to become something that is perking in the background with occasional flare-ups. But I think we may still have another surge coming. I'm just hopeful it's not one that makes it more pathogenic or virulent.
David, what about mixing vaccines? It sounds this is being researched. So if you got Pfizer, should you wait and see if you will be able to get maybe Moderna, or go ahead and get a 3rd dose when you're eligible using a different vaccine?
Well, great question. And the answer is very close at hand. A good article was posted to the preprint server last week from the NIH group and a number of academic centers around the US looking at heterologous boosters. So what they did was they gave people one of the 3 vaccines, and then they gave them a booster with another one of the 3 vaccines. And the good news is that the heterologous boosters were as good as or better than the homologous vaccine. So, and in particular, when you give the mRNA booster to somebody who received the J&J booster, they get a better response. So I think this is going to be really good news for those of you out there who got the J&J who were worried. So my understanding is that the FDA discussed this last week. They didn't come up with a recommendation, but it's going to be taken up probably by the FDA and or ACIP. I'm guessing on Thursday, when they have not, they've posted their agenda, but they haven't said what they're going to, it says they're going to talk about COVID-19 vaccines and boosters. They may talk about this. It may come a bit later, but bottom line is, yes, we've already known from some of the data in the UK and other countries that, and we know from older vaccinology theory that when you use a different booster, you sometimes actually get better immunity than if you use the same, it's called the prime boost. So I think there's something to this, and I would just sit tight. I think we're going to get really good guidance very soon along these lines.
Either of you, the question came in, or comment. We know that many hospitalizations and deaths are those who are not, are in those who are not vaccinated. How often, however, I am asked how many of those who are hospitalized are not vaccinated and have not already had COVID-19.
I don't know that that is information that may be readily available in kind of the statistical information we have access to. It's surely or likely going to be captured in their medical record if in fact they were tested and diagnosed with a prior COVID infection. But we also know that a lot of infections were mildly or asymptomatic entirely and may never have been captured through diagnosis as well. So I think it's a very challenging concept to think about measuring or really understanding what role it may play. But if it was early infection, as Dr. MUSHATT mentioned, the likelihood of any long-term residual immunity from a mild natural infection is likely to be non-significant and not protective.
Yeah, I will say that the vast majority of hospitalizations that we see in this area are unvaccinated persons. There are some who get admitted with who have completed the vaccine series, but they often have significant risk factors. They're often older. They tend to be older. They tend to have other risk factors. But you also have to realize there's essentially a phenomenon where as more of the population becomes vaccinated, then more of the people that get infected are statistically going to be the vaccinated. Okay, it's a little weird, kind of hard to get your arms around that. I have a little trouble understanding that, but I know, but when you look at the math, that's the way it works out. So if 80% of the population is vaccinated, then a lot more people who get it are going to be vaccinated than when only 5% were vaccinated. It's just simple ratios and math.
Again, actually for both of you as well, along those same lines, people who have already had COVID have been my biggest challenge to convince to get vaccinated. So what do you tell people who've already had COVID about getting vaccines?
Well, there's a pretty easy answer to that. There's actually some data that if you had COVID and then you get the vaccine series, you are hyperimmune. You're one of those super immune individuals. And so, what's happening is the vaccine, when given after, is basically boosting the natural immunity. And so those individuals are even more immune. So I would recommend that they do it. Now, there's also some individuals who have COVID and they don't have immunity. Some people have mild disease for reasons, perhaps some genetic, issue in terms of vaccine response. And it's very hard. We still don't really know how to measure how well you've responded to the vaccine. It's still not super reliable. So the bottom line is you're much better off getting the vaccine series after you've had it. It'll almost guarantee that you'll have good protection.
And I think the other piece of it is that the natural infection immunity promulgation is highly variable. And so you don't know what you've got if you're only naturally infected. And especially if you didn't have a substantial and clinically problematic course of disease, which does seem to result in a stronger response. So it's just hedging your bets a little bit. I usually use the example of putting that airbag in place so that you don't have to worry about it so much.
I'm going to take this second question because I think there is an answer to the first in terms of the comparative efficacy of the Moderna and Pfizer vaccine. But the second part of this question is, why should anyone take the J&J vaccine?
Well, the J&J vaccine in its initial trials had actually monitored and assessed its ability to prevent infection, and it actually did quite well. And it also was tested against some of the variants of concern that were circulating in Brazil and South Africa because their test sites were in the J&J trial grouping. And so it's, I think heterologous is an interesting idea, and it works potentially both ways. I can't remember from that the small NIH study you referenced, David, whether people who had received mRNA and then got J&J boosters. I think they had good response, but not perhaps quite as strong as heterologous mRNA.
Right. And just remember that has not been published, it's not been peer reviewed.
Yeah.
So
and
it's
it was
very,
a small study.
very limited
it was
data.
A small study
right.
as well.
If I could just add, I think that what we're going to probably find out is that the J&J may well be comparable to the mRNA vaccines with that second dose. And while it may not be politically correct, and the company may not want me saying this, because certainly what made their vaccine stand out was the simplicity of a single dose. I think that, as others have said this, have echoed this, that it probably should be a 2-dose vaccine. And I think with that second dose, you'll get it up to that, or at least it would have been 94% effective like the Moderna. We'll see how effective it is against Delta.
I wonder too if the vaccination mechanism of giving one type of vaccine and another, for instance, since they're so different, the J&J followed by Moderna or Pfizer, won't become perhaps the standard, because in animal studies, we often do see that the different ways of
and that is what the UK did. They gave AstraZeneca to everybody first, and then they followed with an mRNA vaccine. And
yeah,
they've had excellent results.
This also could be helpful on a public health level, because there are scenarios, not just in this country, but overseas, where it may be hard to give individuals the same dose they received initially. It will allow for flexibility in allocating vaccines. And so this could be a very good thing in more ways than one.
Absolutely.
I'm going to read, actually, there are two comments here, but they're related to each other. There is all sorts of information regarding COVID-19 and its therapy. Recently, I listened to a presentation by Peter McCullough, MD, which was quite damning of the vaccines. Report in JAMA, however, refuted most of what McCullough had said about the vaccines. This is very confusing when experts in the field disagree. Who's telling the truth? Followed by, we seem to see politicians repeatedly step out of their lane and into the science. They announce boosters for everyone when there is no science to support this, as subsequent science panels showed and voted. How can we claim science and medicine for the professionals?
Susan, I'll take the first part, and you
Okay.
take the second. Is that
All
okay?
right, sure.
So I'm familiar with Dr. Peter McCullough. I actually signed an affidavit, basically supporting a hospital that didn't want to give ivermectin, that was involved in a court case. And he, of course, was one of the expert witnesses. So Dr. McCall is a cardiologist. He's not an infectious disease specialist. He's not an infectious disease epidemiologist. He's not a virologist. He also is known to be one of those people who last year was, I don't know if he still is, but he was encouraging the use of these cocktails, including vitamin C and ivermectin. So I know he's got his pedigree, his educational pedigree is impressive. He has been at Baylor, but actually it turns out that Baylor has succeeded in obtaining a restraining order against him so that he does not affiliate himself with Baylor, Scott and White when he makes these claims. So I leave it to your good sense to look at what he's saying. I don't think he's following the science. I think it's a shame but there's always going to be a few mavericks out there like him.
I guess it is a principle in science that the first answer is not the only answer. You usually take the bulk of the data to feel confident about your conclusions. And there are outliers in almost everything in science as well, which have to be discarded. And I think if you look across data and as well as opinion, you might be able to sort out what to follow in science and in terms of physicians. What about the rest of the world? Should we leave this to the scientists and the healthcare professionals?
Well, I certainly would like to see a much greater, I don't know what quite word to use, but respect or at least willingness to listen to scientists rather than politicians for basic, especially public health and certainly medical advice. Because it is unfortunate that certainly in this country and in other countries around the world, this pandemic has become a political football. And it is not productive in terms of getting us through this as efficiently as we possibly can. The challenges that we are facing now with vaccine resistance and some of the obstructions that have been put in place by some political figures is going to continue to be a problem for us as we are trying to bring this pandemic to a close here. And then we have other political leaders in other parts of the globe that are posing equal challenges, sometimes on a national level. And so it is, I think, primarily of the president of Brazil and his approach and perspective on vaccination and the pandemic in general. And so I think it's something that as scientists, we just need to continue to communicate as clearly as we can, acknowledge when we don't have an answer, and then politely but firmly try to steer the politicians to follow the actual data and the information that's available.
On an international note, one of our of the audience commented that the increases in COVID-19 are unrelated to levels of vaccination across 68 countries. And this is in a study in the European Journal of Epidemiology from Harvard Chan School of Public Health. Can you comment on this unexpected finding, if you were familiar with the article or can look at it subsequently?
I am familiar with the article, and one of the big problems with it is that they're using reported cases, which do not reflect actual infections in any country around the world, and most particularly in low and middle income countries. Also, the reality is that this pathogen has moved and affected different parts of the globe and different parts of even individual countries in different time phases. And so to pick a fixed point at which to assess case burden and vaccination levels, even if they were able to get accurate case burden data, which they didn't, I think is unlikely to provide a satisfying answer, because all you have to do is look at what happened here in Louisiana compared to what's happening in Vermont. They, simultaneously, when we were just suffering tremendously from huge caseloads of SARS-CoV-2 viruses and increased vaccine hospitalizations, we were in a low vaccine environment. Vermont is high vaccine and has very little impact. They do have unvaccinated individuals, but they are few and far between, and they are experiencing a much lower impact of this. I think that analysis needed to have far more time-dependent covariates in it, and assess it according to when the virus was peaking and ebbing in the various countries. To pick a single point in time to assess this is methodologically not a very good idea.
David, how can you determine that you already had COVID if you were not tested or got sick before the tests were available at the very beginning of the pandemic?
Well, there's no surefire way to do that, but you can get antibodies. And if your antibodies are positive, then it's more likely than not that you had COVID. But, caveat emptor, that doesn't mean that you're necessarily immune or highly immune. There is some evidence that these antibodies correlate to some extent with not only previous infection, but some degree of protection, but may not be the full story, because of course there's different antibodies. There's binding domain antibodies, there's neutralizing antibodies, and then there's cell-mediated immunity. So there's B and T cell function, which probably persists longer. And so it's a complicated equation, and I don't think we truly know how to determine if somebody is immune. But yes, you can get an antibody test, but it's really not important. I think it's a waste of, I don't order them. I would just go ahead and get the darn vaccine, get your booster if it's appropriate, because if the antibody is positive, you still want to get the vaccine because you can become more immune, and you don't know for sure that that represents protective immunity. And if it's negative, then you're even more likely to want to get vaccinated. So don't get too hung up on these antibodies. It usually takes years for scientists to determine what is a protective antibody level. There's still diseases that we vaccinate against where we don't even know that. We know that for hepatitis B, right? You need at least 9 or 10 million international units, but it took a long time to figure that out. So it's going to take a while to determine those benchmarks.
And because of the cellular components of immunity, circulating antibody isn't necessarily the only marker that would be important in terms of determining that you are in fact protected or not protected. And the cellular level tests are really, really complicated to do and are not generally available for non-research purposes.
David, do you know what the specificity of the antibody tests are?
They're very high. Very high specificity.
Or
I would certainly, I would probably trust, James Robinson or Bob Gary's lab a little bit more, perhaps over a commercial lab, but that's probably just my implicit bias of trusting our own researchers. But I think they are very, like all antibody tests in infectious disease have some degree of non-specificity. There's autoimmune diseases, other states and conditions that can give rise to false positives. Again, I wouldn't get too hung up on these antibody tests. They're just not that useful at this time.
Do we know how long boosters provide additional protection before immunity starts to wane again? How often will we need to get boosters?
I don't think anybody really knows. I've heard a lot of people say maybe an annual booster. Time will tell. It doesn't do any good to speculate on, modeling these antibody levels based on what we know. The human body is way too complicated. Physiology is unpredictable. The virus is unpredictable. We'll find out. We'll know more by next year. And, the good thing is that these vaccine platforms lend themselves well to tweaking if such is necessary. Both Moderna and Pfizer already are working on beta and delta variant boosters in the event that we need them. However, there's some evidence that they may not be necessary, that simply giving the same booster that we are giving now may engender enough of a response to be able to deal with some of the variants that may be out there. But bottom line is, I wouldn't be surprised if we do need some boosters in the next year.
Not surprisingly, there actually are a lot of questions about boosters. It is kind of a new twist to all of this. For those who contracted COVID after receiving the full vaccination series, what are the recommendations for the booster? How long after the infection should one consider the booster? That's presuming that you fall into one of those groups that boosters are recommended for.
Right. So if you had COVID and then you got the vaccine, you would be considered to have hybrid immunity, which means you have very good immunity. Remember, we talked about that earlier. So it works both ways. You could have COVID and then get the vaccine series. You have hyper or super immunity, or you can have get the vaccine and then get COVID, and that boosts your vaccine status. And so either way, there's no official recommendation at this time because there's no data, but some very smart people who are much smarter than me would say you probably don't need a booster if you fall into that hybrid category. However, we'll see what happens as we start to study those individuals. But I think those people can probably relax a little bit and leave the boosters for others.
And I think that it's really important for people to recognize that we have made incredibly fast progress with these vaccines to have so many viable and efficacious candidates, not just the ones in the US, but in other parts of the world as well. And that we are still less than a year from when we started vaccinating people de novo. And so we really, a lot of these questions are things that people are studying with a great deal of effort and focus, but it takes time to figure out these things. We can't rush a biologic process to find the answer. We really have to wait it out and see what the data wind up telling us. It's frustrating because we're kind of an immediate response fulfillment kind of society right now, but there is a lot of work that's going on about duration, post-infection, post-vaccination. Duration of boosters obviously is going to be watched very carefully, but we just haven't had time to figure those answers out yet.
In these waning moments, I have actually been asked a question, so I'm going to take this opportunity to answer, I hope, which is, Dr. Blanton, are you concerned with the long-term ability to provide vaccines and booster third doses to developing regions? Are there ways to help bolster the global effort for distribution? Very important question that is, we have already discussed, and not here, but among ourselves. And I know that there is an initiative at present to increase the ability of people to make vaccines abroad, which is also an initiative here in the United States that people want to bring back manufacturing because of these vital things that we're all going to need. But they're talking about developing them in Africa. And I am a cheerleader, at least for Africa, in that one, you notice that there, in many places, there is a much lower COVID infection rate and death rate. In some places, South Africa is not one of them. And I don't know, some of that is because of the demographics of the country, but it's also because the Africans themselves are much better put together and better organized. They have better governance. There is an African CDC in which people have been sharing information. They're good at doing contact tracing because of their experience with epidemics in the past. And they're looking to develop in South Africa, of course, the ability to produce vaccines locally, because it's felt that the ability to do that means that you don't end up shipping all of your vaccine elsewhere or have to beg for vaccine from elsewhere. And they're going to use that facility. And this was just, I actually just knew this recently, began to use that as a training facility to disseminate this technology, which Moderna has allowed people to use without contesting their patent. So
Yeah,
go ahead.
I just heard that story this afternoon. I can't remember the name of the company in South Africa that's working on replicating the Moderna vaccine, and Moderna is not going to contest. And I mean, India had always been the producer of vaccine for Africa for so many diseases, but they got hit so hard with their own wave that they have basically retained all of their production for local utilization and vaccination programs. And that's why it's so critical to get vaccine production in every region. Latin America needs their own vaccine production ability capacities. South Asia, Sub-Saharan Africa, probably multiple locations to enable appropriate production and distribution.
And this new technology, I think, will be revolutionary in terms of it won't solve everything, but there are many other conditions that it can be applied to very easily and very readily. So I think once it's installed and established, I think we can have a better distribution of vaccines around the world. We have come down to the end of the hour right now. I want to thank all of our discussants, as well as everyone who has attended this webinar. I hope it has been informative to people. Again, things have changed. We brought you up on some of the newest things that people are seeing, some of the new problems we never discussed earlier because we didn't have, or opportunities we didn't have prior to this moment. And I'm sure that this is not the end, that there will be new things that come out, as David has said, almost every day there's something new. And this may need to be repeated in terms of catching people up on what's the latest with this pandemic that seems not to be never ending. Did you each have a final comment?
I think that it's just that we do need to recognize that this virus has fooled us several times before, and we do need to keep keep our eye on it and do whatever we can collectively to try and get it under control for all of our sakes around the globe.
Yeah, we used to say in the early days of HIV, it's the virus, stupid. And so here I could probably translate that into it's the vaccine. So yeah, clearly we've got to get people vaccinated because that's the only way to really squelch the reservoir of people that have virus that's going to mutate and cause new variants to emerge. And as I also mentioned, I think there's some hope on the horizon with some promising new oral antiviral agents. There's some talk that they may need to be combined. It's monotherapy may engender the development of resistance. And so you may, along the lines of treating TB or HIV, you may end up using 2 drugs, but there's, one that should be approved by the new year and several others that look promising. So I think there's some light at the end of the tunnel, but let's get everybody vaccinated.
Well, we have sort of only scratched the surface in terms of COVID, but we've also only scratched the surface in terms of the questions. We will be answering, replying to the questions by email. So don't abandon hope. We plan to reply to all of these. Well, I want to thank everyone once again. And I think we'll end.
Thank you.